So let's go beyond the sentinel node. Let's say you have your patient with stage 3 disease. What's the approach to adjuvant therapy? In other words, we just heard at this ESMO the first survival data. So can you just recap, Axel, the survival data on the ipilimumab trial and tell me, will this change the way you talk to patients about possible adjuvant therapy?
You know, when Lexagamon presented this trial for the first time at ASCO, 2 years ago already, or it was last year, but 2 ASCOs ago,
yes.
There was rumor in the room because relapse-free survival looked very promising, but overall survival data were not available. And there was a lot of toxicity. And everybody was saying, well, does this toxicity outweigh the benefits of the treatment? And now that we have a positive trial in terms of improvement, significant improvement of overall survival by 28%, so hazard ratio is 0.72 for high dose, I call it high dose ipilimumab compared to placebo. There is certainly a good reason to explain this to the patients, It's certainly not a drug which can be given at this high dose to every patient, and there is substantial toxicity, but I think we need to discuss it, and certainly there is the issue if in the future we can use lower dosages of EP or other checkpoint inhibitors, but at the moment it's the best data which are available. But Jeff, you are from the US, we are from Europe. In Europe, there is much more competition because it's not only high-dose interferon which is approved for this setting of stage 3 patients, it's also the low-dose interferon, which was in Germany much more popular to use in the adjuvant setting than high-dose interferon because high-dose was so toxic.
Yeah, although in the US there's little penetration of low-dose or PEG interferon use in the US and less interferon, and I think especially in view of the survival data, there will be perhaps more penetration. But Reinhard, I mean, how do you look at patients getting high-dose ipilimumab? I mean, what do you say? What do you tell them?
So until now, interferon was the only drug available, and actually in Switzerland we have pegylated interferon on the market. And I have to say that I have restricted the use of pegylated interferon to patients with ulcerated primary plus micrometastasis. And for patients with a nodal disease, with a major nodal disease, actually, I said interferon makes no sense, and certainly we tried to bring them in clinical trials, but unfortunately this was not always possible. And this is the patient population today that has another option. So with the data that we have now out there with ipilimumab, this is a patient population with a high risk for relapse, and with the 28% improvement in survival, I think this is an option that you have to offer to the patient. And the discussion about the risk-benefit will be a tough one, because we will have to face a number of significant toxicities, the acute toxicities with colitis that may become life-threatening, especially if not well handled, and then we have the probably lifelong problems with endocrine functions.
Yes, which is not that easy. I mean, in the metastatic setting, it's easier to accept. But in the adjuvant setting, to take pills every day because you are hormone insufficient, it's not that...
Yeah, but I mean...
So Dirk, how do you risk adjust this?
Yeah, I think for high-risk patients, 3C, I think there's no option. And I mean, we have complained for decades about no true evidence that interferons will translate into an overall survival benefit. And I think there is also clear evidence that interferon, if it works at all, it works best in patients with minimal tumor load in the sentinel. So now for the first time, actually, we have clear data showing a convincing long-term overall survival benefit with EPI. So nevertheless, I agree with Reinhard. I think for high-dose EPI, we need patients who are compliant. We need an educated environment so that actually actions can be taken early on. So you need a good working network in order to be safe yourself and your patients is safe. And the patient needs to actually be involved in the decision making, and you need to discuss the risk-benefit ratio with the patient. And if the patient is accepting that, I think you can go for that. I think the attitude, the cultural differences will also drive some of the decisions. So I think in some parts of the US, I think high-dose interferon with its toxicity was also much better accepted than in some parts of Europe. I think there are differences in perception of the risk-benefit ratio, but I clearly believe that this is a step forward.
But you know, I like to make one comment. If you go to the details of the EOTC study, which was presented at ESMO here and published in the New England Journal yesterday, you know, you see that the best patients are still those patients with low tumor load on the sentinel node, which means the N1 population, the 2BC patients, so the ones with relatively low tumor load, whereas the patients with bulky lymph node disease, macroscopically lymph node positive patients, are doing less good.
Although,
for compared.
Unlike some of the interferon trials, though, there appeared to be, with the Egremont presentation, benefit both for the bulky patients and for the low disease burden.
I agree, but there's a difference, right? So the patient with low tumor load, as always, do better. So I believe there's still a very high medical need if we are talking about perspectives for those patients with a high risk of relapse and the risk for a very early relapse. Which means it could be one day that these patients are more or less treated as stage 4 melanoma patients, because you know the risk for relapse is so high, and the relapse comes within weeks or just a couple of months, and they are considered, you know, in the behavior and metastatic spread pattern
because
as patients like stage 4 patients.
Because most of them are indeed
It could be, you know, the approach hit it hard in the adjuvant setting as well.
So, but